Welcome to this comprehensive guide on congenital heart malformations. Today, we will explore the 8 most common defects encountered in clinical practice. Congenital heart defects are primarily categorized based on whether they cause cyanosis, a blue tint to the skin, resulting from oxygen-poor blood entering the systemic circulation. We begin with non-cyanotic defects, characterized by left-to-right shunts. Here, oxygenated blood is diverted back to the right side of the heart, increasing pulmonary blood flow. The most common congenital heart defect is the ventricular septal defect, or VSD. This involves an abnormal opening in the interventricular septum. Pathophysiologically, the high pressure in the left ventricle forces blood into the right side. Over time, this leads to right ventricular hypertrophy and pulmonary hypertension. The hallmark clinical sign is a harsh, hollow systolic murmur, loudest when auscultated at the left lower sternal border. Next is the atrial septal defect, or ASD. This is a hole in the septum between the two atria, most commonly occurring at the ostium secundum. This creates a left-to-right shunt at the atrial level, increasing the volume of blood the right heart must handle. A key diagnostic feature is the characteristic fixed-split second heart sound, which does not vary with respiration. Patent ductus arteriosus, or PDA, occurs when the fetal connection between the aorta and pulmonary artery fails to close after birth. This allows oxygenated blood to recirculate through the lungs, potentially leading to heart failure if the shunt is large. On exam, listen for a continuous machine-like murmur heard throughout both systole and diastole. We now move to obstructive defects. These conditions involve physical narrowing that restricts the flow of blood through the heart or great vessels. Coarctation of the aorta is a narrowing of the aorta, typically located distal to the origin of the left subclavian artery. This obstruction causes hypertension in the upper extremities while resulting in weak or delayed pulses in the lower extremities. Clinically, this is identified as radiofemoral delay, a critical finding during a neonatal or pediatric physical exam. Pulmonary stenosis involves narrowing of the pulmonary valve, which severely increases the workload on the right ventricle as it pumps blood to the lungs. Look for a systolic crescendo-decrescendo murmur at the left upper sternal border, often accompanied by a palpable thrill. Aortic stenosis is the narrowing of the aortic valve, obstructing blood outflow from the left ventricle. The heart compensates for this resistance by thickening the left ventricular wall, a condition known as left ventricular hypertrophy. Finally, we examine cyanotic defects. These involve right-to-left shunts, allowing deoxygenated blood to bypass the lungs and enter systemic circulation directly. Tetralogy of Fallot, or TOF, is the most common cyanotic lesion and is defined by 4 distinct anatomical features. First, pulmonary stenosis and right ventricular hypertrophy. The narrowed valve forces the ventricle to work harder to oxygenate blood. Second, an overriding aorta that sits directly over a large ventricular septal defect, allowing mixed blood to enter the systemic flow. Patients may experience TET spells, episodes of profound cyanosis during crying or feeding. Older children often instinctively squat during these spells, which increases systemic vascular resistance and improves pulmonary blood flow. In transposition of the great arteries, or TGA, the aorta arises from the right ventricle and the pulmonary artery from the left, the opposite of normal anatomy. This creates 2 separate parallel circuits. Oxygenated blood never reaches the body unless there is a shunt, like a PDA or VSD, to allow mixing. On a chest X-ray, TGA often presents with a classic egg-on-a-string appearance due to the narrowed mediastinum. Understanding these defects is critical for anticipating potential complications and long-term management strategies. Eisenmenger syndrome occurs when a long-standing left-to-right shunt causes irreversible pulmonary hypertension. The high pressure on the right side eventually exceeds the left, reversing the shunt to right-to-left and causing chronic cyanosis. Diagnosis is primarily achieved through echocardiography, which provides detailed visualization of the heart structure and blood flow. However, the physical exam remains your most powerful initial tool, providing critical clues through murmurs and pulse discrepancies. As a future RN, your ability to recognize these subtle signs early can be life-saving for your pediatric patients. Quickly review: VSD shows a hollow systolic murmur, ASD a fixed split S2, and PDA that machine-like continuous murmur. For obstructive defects, remember the crescendo-decrescendo murmur of pulmonary stenosis and the radiofemoral delay of coarctation. And for cyanotic defects, associate Tetralogy of Fallot with TET spells and squatting, and TGA with the egg-on-a-string chest X-ray. Management often requires a multidisciplinary approach, spanning from surgical repair to long-term pharmacological support. Modern surgical techniques allow for many of these defects to be repaired early in life, significantly improving long-term outcomes. With early detection and advanced intervention, the prognosis for children with congenital heart malformations has improved dramatically. For your nursing exams, focus heavily on the specific murmurs and unique physical findings associated with each defect type. Consult sources like Rhesus Medicine and your clinical textbooks for deeper dives into the hemodynamics of these conditions. Thank you for watching this guide. Stay curious and keep learning. Your expertise is the heartbeat of patient care. See you next time.